Good afternoon, everyone. I'm Jeff Tiemann, President and CEO of the Vermont Association of Hospitals and Health Systems, which represents our state's network of nonprofit hospitals. Thank you so much for joining our press conference today on a really important topic for Vermonters and for the people who provide their healthcare. And thank you to the panelists I will introduce shortly, who are going to join me in commenting and responding to your questions. I want to begin by saying to anyone out there who has tried to get a medical appointment that was difficult to schedule or who has waited a long time to see a specialist that we need to do better. I know from my own direct experience that hospitals in Vermont focus every single day on meeting their mission and treating the people who need their care. And they are always devastated to know of instances where they may have fallen short. This is also a personal issue for all of us, me included. The people we're talking about are our family members, our friends, and our neighbors. We all deserve to access the medical care we need when and where we need it. Unfortunately, especially here in Vermont, there are just not always the right number of physicians and nurses and other staff in every specialty to make sure that always happens. There just isn't. And we are barely emerging from a pandemic that disrupted healthcare delivery in every conceivable way, but also showed the mighty strength of our small hospital system in helping manage Vermont's nation-leading response and caring for people under the toughest of circumstances. You know, Vermont is a rural state, and providing healthcare in rural America is extremely challenging. It is a lot easier, for example, to recruit a cardiologist to Boston than it is to Brattleboro. Easier for many reasons for a dermatologist to move to Philadelphia than to Randolph or Bennington. So the AHS report gives us a sense of the scope of the access and wait time challenge, but it only tells part of the story. Together, we also need to look at workforce and our regulatory structure, which is unlike any other state, and has focused a lot on the cost component, which has limited hospitals' ability to make the right set of investments that are needed to improve access to care. We also need to look more carefully at the data, because this is a 188-page report, and hospitals have not yet had the opportunity to thoroughly review or respond to it. Based on what we do know, the data does have some challenges, including what it may leave out, like our workforce shortage, which was serious before the pandemic, but even more severe now. And we have concerns about the secret shopper exercise, which was conducted during a major surge period of the pandemic and put unneeded stress on hospital staff members at a very difficult time. It also produced results that may not be complete, or at least a completely accurate reflection of wait times, given the large number of hospital staff who were out at the time with COVID or quarantine as those calls were placed. With all of this as a backdrop, I think it's important to highlight that hospitals have been partners with the state since day one of the pandemic, and well before that. Our response to COVID-19 was effective in Vermont precisely because we worked together in partnership, side by side with the state. And when we do that, great things happen for Vermonters. I believe, and so do our hospital leaders, that collaborating on access issues and wait times can be another example of making improvements by bringing all of our collective resources and thinking to the effort. That means hospitals and healthcare providers. It also means the state and our regulator and our legislators. So with that, I thank you for joining us. We have a panel of speakers here with me to help describe the challenges we face in delivering the best possible care to Vermonters, as well as the opportunities we have and how hospitals are working every day to improve and do better by the people they serve. So I'm going to start by turning to Claudio Fort, President and CEO of Rutland Regional Medical Center, and also Chair of the Vermont Association of Hospitals Board of Trustees. Claudio?
Hey, thanks, Jeff. You know, in rural healthcare, access to specialists is one of our significant challenges. This is not new news. Many of my colleagues and I have spoken about these challenges publicly for years. Throughout this time, we have also seen Vermont hospitals implement new and innovative programs and services to preserve and expand access to essential specialty care in our communities. We can cite numerous examples, such as the Westridge Center for Addiction Recovery that Rutland Regional started here some 12 years ago. Prior to that time, there was no access to clinical treatment of opioid use disorder here in Rutland County. In fact, every Vermont hospital can describe dozens of similar initiatives that they have led in their communities to ensure access. If Vermont's nonprofit hospitals had not stepped up to the plate over and over again throughout the years, there would literally be no access to many critical specialty services anywhere in Vermont. But Vermont hospitals do recognize that more needs to be done. And as with nearly every major challenge we face here in Vermont, no one of us can do this alone. We need the support and assistance of the Green Mountain Care Board, the Agency of Human Services, our state and local legislators, the health insurance providers, and our federal representatives and senators to ensure that Vermonters have access to the care they need and deserve. This year marks my 14th year as a hospital CEO here in Vermont. When I first came here back in 2008, there was a lot of collective focus on access to healthcare services. And together, we came up with numerous innovative and leading advances in expanding access to care and access to insurance coverage through programs like Dr. Dinosaur and the Blueprint for Health. However, over the past several years, there has been almost no focus on access. These discussions have all been crowded out by the almost singular focus on healthcare costs. Many of us believe that investments in access, like the Blueprint for Health, can actually lower healthcare costs in the long run. These problems are extremely complex and have no easy or simple solutions. Our doctors, administrators, and the patients of our communities have been aware of and have been addressing these challenges for many years. As we understand it, the study commissioned by the Agency of Human Services begins to identify these challenges, but does little to diagnose the root causes or propose workable solutions. We need the support and collaboration of policymakers, payers, and regulators if we are to make any meaningful progress. And we look forward to rolling up our sleeves and working together to protect and expand access for all Vermonters. Thank you.
Great. Thank you so much, Claudio. Next, we're going to hear from Sean Tester, who is President and CEO of Northeastern Vermont Regional Hospital in St. Johnsbury. Sean?
Thanks a lot, Jeff. You know, I'd like to start with a story, a personal story. 3 years ago, we lost my grandmother. Emma was an amazing woman who was independent all her 93 years up until the last 3 months of her life. In those last 3 months of her life, as her health declined, my entire family really wrapped around her to support her care, including the increasingly frequent trips to physician appointments, specialty appointments, etc. This was in the dead of winter, cold and snowy winter here in the Northeast Kingdom. We would pick her up at her antique farmhouse, put her in her car, drive her to her appointment, deal with the icy sidewalks and roads so that she got the care she needed, including her primary care physician, her palliative care consultant, her cardiologist. The entire time my family did that, we reflected on how lucky we were to have that access right here in our own community. That access, especially in regions that suffer socioeconomically compared to other regions of Vermont or even the nation, is incredibly important for people. You're simply not going to get them to travel the hour plus down to Dartmouth or the hour and 45 minutes to Burlington for those critical care appointments. So having those physicians in our communities is essential. I'd like to tell you a little bit about one of our specialists here, Dr. Amanda Van Straten. She's our neurologist. We have one neurologist in this little corner of the state. She's an amazing physician. She's invested in her community and she provides amazing care. We don't have a second. So when Dr. Van Straten is out on maternity leave or takes time off for vacation or is sick with COVID, there's nobody here to pick up the slack. Those appointments get delayed or deferred. That's just the way it is. We can't afford or support a second neurologist, even if we could find one. Finding and recruiting specialists to our rural communities is incredibly challenging. Right now, we have 2 of a team of 3 general surgeons. We lost one a little over a year ago when she decided to relocate closer to home. We've been recruiting for that position for over 1 year. Just last month, we made an offer to an amazing general surgeon who we felt was going to be a great fit for our community. We were excited about the prospect. She seemed to be really interested in the opportunity until she called us up a week later and informed us that she accepted a position out of state for 30% more pay than what we were able to offer. In addition, housing has become a much more significant challenge when it comes to recruiting professionals to our environment. Just last month, again, we made offers to 2 healthcare professionals who accepted our offers, started looking for housing, and was simply not able to find something that met their family's needs. So they had to move on and pass on those opportunities. What this means is that rural hospitals and health systems need to be really creative in how we solve these problems. Our partnerships with our state college systems and UVM are essential to growing our own workforce. And we feel that they are a cornerstone foundation of what the future workforce will bring us in this region. It's also necessary and important for us to continue to partner with the larger health services, healthcare institutions in our region, including Dartmouth and UVM. For example, our own pathologist is a UVM Medical Center employee, and he's fantastic, and we love that relationship. Likewise, our cardiologist is a member of the team at Dartmouth. It's interesting to see us having to get more and more involved in areas outside of our scope to help solve these problems when we're trying to bring people to the area, including around housing and trying to find jobs for spouses, because it's not just the healthcare professional you're recruiting, but you're really recruiting an entire family to your region. Now, despite these challenges, I am very proud of what we've been able to accomplish and the quality of care we are providing within our community. Thanks, Jeff.
Thank you, Sean. Next up, we're going to hear from Dr. John Brumstead, who is the Chief Executive Officer of the University of Vermont Health Network. John? John, you're muted. There you go.
Thanks, Jeff. Thanks, Claudio and Sean, for those great words. And I'm sure Kat will hear great words from you too. And I just have to say that I'm humbled and really proud to be on this panel with professionals that have dedicated their lives to Vermonters getting access to the care that they need. And I wouldn't be able to stand here and not say how grateful I am to the 1,000 or so physicians that work for UVM Health Network and all the other physicians serving Vermonters, the nurses, the technicians, and everybody who shows up day in and day out to provide the absolute best care we possibly can for Vermonters, and to do so when we know that access to services is not always what we would like it to be. For the UVM Health Network, we've been very clear. We've owned the issues, pre-pandemic issues around access, and to be able to communicate better, we have brought what we're doing to address the access issues together in an access report that really focuses on 3 areas. One is workforce. We all know how hard it is, but to do everything we can to recruit and retain professionals, as Sean spoke, it's very, very difficult. Great example of that is the recent work at the UVM Medical Center, where we've gotten agreement with the nurses union for salary increases that we believe will greatly enhance recruitment and retention. So workforce, we're all over it. That's just one example. A second is to reduce wait times for specialists, and I'll come back to that in a second. And the third is to increase capacity in our inpatient and our emergency areas. And that particularly having the state's academic medical center is an area that we've really focused recently. And that really has had a bit of a negative impact on our work for specialty access, because it was all hands on deck and has been to increase that inpatient capacity. But we've made progress there too. We've reopened the Fanny Allen campus for inpatient rehab, which increases capacity on the main campus at the medical center. And just Monday, we reopened the Fanny Allen operating rooms. So the capacity piece, we're working on very hard, and there's many examples of that. One example that I'd like to give that highlights the complexities of addressing access issues, the length of time that we've really been focused on access issues, and some of the peculiarities of being in the regulatory environment that Jeff Tiemann alluded to, and that's dermatology. Dermatology is everybody's favorite example of difficult access. And so knowing that, almost a decade ago, maybe even a little bit longer than a decade ago, we started a dermatology residency at our academic medical center so we could train more. That starting a residency takes 3 to 5 years of applications and process. So we have that. We have a training program, scheduling. To do the scheduling, we need to have an electronic health record that had scheduling modules. That's Epic. We've been in process of putting that in place. And you need to have, using that scheduling system, a centralized scheduling function. And we're building that out, and they're focused on dermatology. Again, another several years. And part of that electronic record is the ability for dermatologists to do what are called asynchronous visits. Your primary care doctor takes his or her iPhone, takes a picture, sends that to the dermatologist of a skin disorder, and the dermatologist then on their own time reviews that and gets back to the primary care doctor. I need to see that patient, or this is what you can do. You have to have the technology to be able to do that. It's part of our access plan. We're implementing that. Facilities. We have a need for expanded facilities for the more dermatologists to see more patients. And we have submitted a certificate of need to fit out a building on Tilley Drive in South Burlington for additional capacity for our dermatologists and to do the specialized work that they do. Again, a certificate of need process. If we were in New York or New Hampshire or Maine, we would go out, we'd do internally a review of if we needed that facility, and we'd go find the money and build that facility. In Vermont, you have to add in for the CON process months, and in some occasions a year or 2 years into the process to get your regulatory approval. So that's part of what we live with in Vermont. I would ask that as part of the access report that's come out, that we not just look to the delivery system for all the solutions, but that we look directly at the processes, the regulatory processes in the state of Vermont, and make sure that those are not impeding our ability to address the access issues for Vermonters, but are facilitating and enhancing those those efforts. So thanks, Jeff, and again, thanks to my colleagues for being on the call.
Great. Thank you, Dr. Brumstead. Our final speaker in our formal lineup today is Dr. Kat Mcgraw, who serves in two roles. She is the Chief Medical Officer at Brattleboro Memorial Hospital, and she also leads our Chief Medical Officer group, which met routinely throughout the pandemic to help the state and each other coordinate our response to COVID-19. And I saw Kat in action week after week and leading that group with skill and finesse. It's a tough group and at a tough time. So welcome, Dr. Kat Mcgraw from Brattleboro.
Thank you, Jeff. Yes, I'm here on behalf of the doctors, nurses, and other frontline staff in Vermont, as well as on behalf of the chief medical officers who've been leading medical care in our Vermont medical systems. So I will start that by saying that providing medical care during COVID has been extremely challenging for all of our frontline staff. Our doctors, our nurses, and all of our other caregivers are dedicated to the mission of providing excellent care to our communities. The fact that each of us gets up every day to come in and treat patients during this crisis has annealed us. It's made us stronger, more resilient than we ever dreamed possible, and it has affirmed our commitment to working tirelessly to doing the right thing for our patients in the hospital, in the ED, and in the outpatient setting. Over the past several years, our frontline staff have done amazing work, which is not unrelated to the concerns brought up today by AHS. We have been at our patients' sides as our entire health systems have pivoted to provide healthcare services never before imagined. In our most difficult times, we have had to triage and limit some less urgent services in order to provide that which was most necessary. We deferred some elective surgeries in order to accommodate the most urgent surgeries while also caring for COVID inpatients. We transitioned to telehealth in order to ensure access continuing while creating enough capacity to also provide testing and vaccination for our communities. Our hospitals and clinical staff have kept our fingers on the pulse of what has been most needed for patients during this constantly evolving pandemic. And we have been there to provide that care at a scale never before imagined. I often tell my colleagues in other states that here in Vermont, we have the benefit of being a statewide healthcare team. Our nonprofit status and way of working collaboratively has meant that all of our hospital chief medical officers come together during this pandemic, meeting weekly or more, to support each other's efforts to address our community healthcare needs across the state. We have been sharing best practices with each other, avoiding duplicating efforts in creating responses to problems, and learning from each other's approaches, both our successes and our failures. This has made us much more efficient and responsive than we would otherwise been able to do. With all of this concentrated focus and collaborative response, Vermont has been able to lead the nation in response to the pandemic. More vaccination, more testing, fewer deaths. This hasn't happened by accident. And it must be noted that this entire study produced today by AHS took place while we were doing this essential work. We know our work is ongoing and there is much more to do, but we have focused on providing access during this pandemic and will continue to do so. I know as a physician that long wait times are not helpful for anyone, patients nor providers. We will continue to bring the lessons that we have learned about access and responsiveness to all needed medical services. We remain committed to making progress to ensure that all our patients have timely access to the care that they need. Thank you.
Great. Thank you, Dr. Mcgraw. And thank you to all the panelists who made really compelling and helpful remarks by way of explaining the situation we're in and the work we're doing every day to make sure Vermonters have the access they need. So with that, I want to open it up to a question and answer session with the reporters. Couple notes on that. And this is going to be a webinar exercise. I haven't necessarily done this way before, so bear with me. But this is the Q&A is for reporters only. I know there are some participants on the webinar who are not official reporters or members of the media. So please refrain from asking questions unless you are a member of the media. And once you do, please identify yourself as well as the media outlet that you represent so we know who's asking the question. And I believe you can ask questions either by raising your hand and I'll be able to call on and unmute you, or you can put a question into the Q&A box and I'll be able to monitor that. So with those instructions, I will open it up and start the conversation.
So we have a question from Colin Flanders and one from Pat Bradley. Jeff, do you want to call on one of them?
Let's start with Colin Flanders. Go
Yeah,
ahead,
you can go
Colin.
ahead.
Hi, can you hear me?
We can.
Great, thank you. Thanks for being here today. So your points about the potential shortcomings of the study, and in particular the secret shopper survey, are well taken. I'm just curious, if the hospital providers here today think that the data reflected in the report is not accurate? In other words, I'm assuming that they have access to the data for their individual hospitals. So UVM, for example, I think it was around 100 days was the average wait. Is that longer than what it actually is, or are you just saying that it's missing some context?
So Colin, let me start and then I can turn it to our panelists. I think it is important to know that we got a preliminary look at some of the data included in the report. We did not see the entire report. And some hospitals may have seen data, but others did not. And I also think, given that, it's important that we have the time needed to look more carefully at the conclusions that have been reached and the methodologies that were used to reach those conclusions. You know, are we talking about comparisons that are apples to apples? Does the data reconcile with what hospitals know of their own services and their own experience? So those are kind of questions that we need to get answered here. But I'll turn it to the panel to address that, if there's anyone who wants to take it up. Claudio, you want to start?
Yeah, I would also echo that it's hard to know, not having looked at the data. These are very complex issues, access to care and what type of care, what level of access you need. So we really need to be able to have some time to look at the methodology and the actual data and be able to compare that with what we know from our internal records.
Thank you, Claudio and Jeff. I agree. I don't haven't had time to do a deep dive in understanding for UVM Medical Center of 101 days really reflects reality. Directionally, there are access issues, and I'm not going to step away from that. I had all of 15 or 16 minutes to look through the report. So at a very high level, my biggest concern with the methodology is what Claudio just referenced, or Jeff, maybe you did, looking at any of the comparisons, whether you're comparing different hospitals or geographies in Vermont, or particularly if you're comparing Vermont access to access outside of the state. Those comparisons are all going to be apples to oranges, or pick your other fruit. And they are so nuanced that that's where we need to dive into the report to be able to explain where some of those differences exist. But I would be very, very careful to put any credence into the comparisons that are drawn from these data.
Does that include comparing UVM to Dartmouth, which I think most people kind of think of as similar in their mind?
Well, that's a great question, but that goes directly back, Colin, to what I said about the regulatory differences. So you can't compare those without saying that New Hampshire doesn't have a CON law, and New Hampshire does not have a hospital budget process, which has restricted revenues and growth. So there again, apples and oranges.
I hear what you're saying. I mean, that's context behind it, but I'm just talking strictly about the data. And so can you compare UVM to Dartmouth just as far as the data goes, and then have some context in there saying but we also know that the regulatory structure in Vermont is different. I mean, I guess that's what I'm trying to get at here is this a big problem with the data we're talking about, or is there a lack of context that you think should have been in the report? And what I'm hearing is that it's a little too soon to say on the data front because you haven't really crunched it yet. Is that
Too
fair?
soon on the data front, but the context is clear as the nose on everybody's face.
All right, I'll step back for a moment, let other people jump in.
I think maybe Dr. McGraw wants to add.
Yeah, I'd just like to add to Dr. Brumstead's comments that I think we can't step away from the time period that this survey was done. The comparative data, while we haven't been able to dig into much of any of it, we can say that the comparative data did not come from the same time period. And the time period of these secret shopper calls was at the same time that we were dealing with the Omicron variant, and our staffs were very stretched. We had redeployed staff from various areas of the hospital to cover other areas of hospitals so that we could be sure that our patients would receive their medications and their treatments and their nutrition in a timely manner. And that redeployment has an impact on our facilities broadly. And so without accounting for that, we really are looking at apples and oranges, and we can't forget that.
Okay, well, sorry, I am going to jump back in here then in response to that. Do you believe that if this study was performed, say, last summer when case counts of COVID were low, that the data would have been more favorable?
So Colin, I'll just say, I think it's possible that it would have been, or at least it would have been different. And I also think it's important, just as a piece of clarification here, we do recognize that the secret shopper piece was one component of a larger study that did look at some data over time. But again, to the point that several of us have made, we would need to dive into that data to be able to sort of answer the validity question a little better. And with that, I want to move on to another reporter. Who do we have next? Beth, do you have someone on deck?
Yeah, Pat, I think is next. So I'm allowing you to talk now, Pat.
Pat Bradley, welcome.
Hi, how are you?
Fine, thanks.
The report that you are referring to, it seems like you're responding to it in a lot of generalizations regarding, the access issues. And I'm curious, regardless of the report, people have been complaining about access for some time. So what specifics are the hospitals doing to improve access? And also secondarily, when you talk about the secret shopper aspect of this and question the whole skewing particular of the data with the secret shopper, does that kind of skew the entire report's data, do you feel, to make it inaccurate overall?
So once again, I'll start. Thank you for the question. On the issue of what hospitals are doing, I think we have some folks on the call who can help answer that question in just a moment. I will say that one of the key things they're doing is working in as many creative ways and partnerships as possible to build our workforce, whether that's directly partnering with educational institutions to make sure that we have a nurse pipeline, and helping educate future workers to stay here in Vermont. That's one of the first key things that needs to be done, but there's also a series of access initiatives that I think Dr. Brumstead can speak to from the network's perspective, as well as other people on the call. And then I can get to your other question about the secret shopper. But first, Dr. Brumstead, do you want to start with that one?
Sure. And Pat, I'd refer you to our access report, which we've made widely available, and we've actually done several updates and press releases on, and that is very specific and with timelines. There are a number of things on that. In the workforce area, we've increased the number of recruiters that we have. We have gone to an outside agency that normally helps us procure travelers And they also have an arm that helps turn travelers into permanent employees. Back to what Sean Tester told us, it's really, really difficult in our three areas in Vermont for people to have housing, and that's a big barrier. We've put much more resource into salary support for nurses and other frontline clinical staff as far as retention bonuses. So there's a whole list of things there. On the specialty referral side, we've put in place some technologies and workflows that you can only do when you have an electronic record like Epic. So as soon as we've gotten that in, and we've just finished all of the Vermont hospitals and all of our Vermont doctors on Epic, so that specialists can provide insight into the care of patients that primary care doctors need help with, without the patient actually needing to go see the specialist. The so-called e-consults, those are in place. And we have a number of certificate of needs that we've put forward for facilities. Back to what I said before, if we were in a different state, in a different environment, those facilities that are dramatically and desperately needed, we'd be much further along in the actual breaking ground phase on all of those projects, but they go through a certificate of need process in this state. So there's a lot of specificity, and Pat, I'd refer you back to that report because I just gave you a thumbnail of it.
Okay.
Great. And Pat, since your question's so important, I do want to turn to the other panelists on it, starting with Sean.
Yeah, Pat, one thing that has amazed me as one of the probably newer hospital CEOs in the state is just how involved I've become in the housing issue. I can't understate how big a challenge that is for the Northeast Kingdom. Whether it's working with the Northern Forest Center to redevelop properties in downtown St. Johnsbury, working with the St. Johnsbury Town Administration to collaborate on recruiting developers into our area to develop new housing stock. I mean, it's really just astounding. I mean, we, for travelers, we ended up having to rent a dorm from one of our local high schools to house travelers because there's literally no place for them to live when they come to work at our hospital. So, that gets to my point earlier around we really have to be creative and think outside the box. I don't think there are easy short-term solutions to the access issues. When we do recruit physicians to our area, it's we take an all hands on deck approach. We wrap around the physician, their spouse, their family to make the whole family feel welcome and show them the area in the hopes that they fall in love with it and want to make this place their home.
Kat, do you want to go next, and then Claudio?
Sure. I want to just add from a smaller hospital standpoint, we put a lot of effort into thinking of creative solutions to access. We have put some energy into telehealth as one perspective on that, so that we can extend our ability to provide some of the more specialty services that we would otherwise not have available in our small rural areas. We also look at collaborative recruitment with some of our larger partners, UVM, Dartmouth, recruiting specialists who will provide some of the care here at a smaller facility as well as at the larger facility, knowing that that is an enticing potential appointment for a new recruit. And then lastly, I think we can't overlook that there has been considerable effort that has gone into preserving the access that we have. As our workforce ages, really working to find collaborative solutions between ourselves and those care providers to ensure that they continue perhaps at a smaller panel size, or part-time basis, just to extend that coverage and really preserve the access that we do have as it stands right now.
Claudio, do you want to chime in?
Yeah, and I think I don't think what you're hearing from any of us on the hospital, from the hospital community, that anyone is disputing that there are challenges with access. We've recognized that for years. And it's part of the deal about being a healthcare administrator in a rural setting is it's somewhat endemic to the rural environment. And that is one of the things that all of us, I think, focus on all the time and keeps us up at night. How do we get access to critical specialties? And we have all done numerous things, and we could spend a lot of time talking about what we've done in the past. I think the real question is, how do we move forward together and find ways to do this? And our concern about the methodology, at least from my seat on the report, is I think it's concerning. These are very complex, interrelated issues. And if the methodology isn't right, it might start leading folks to go and try to solve this with solutions that just won't work. And I can tell you, no one of us, the legislature or the Agency of Human Services or our regulator or the payers or the hospital community will be able to do this alone. None of us have the answers because there's a whole host of factors that weigh in on that. So we are very willing to continue this conversation and continue to come up with new solutions. Some of them cost money. I mean, that's just the basic economics, and we have to factor that in as well. So we agree there are challenges with access, and we're willing to continue to look at how we can solve those together.
Thanks to all the panelists in answering Pat's question. I do want to take one from the Q&A, which is from Dan D'Ambrosio at the Burlington Free Press. He's asking a follow-up question if we're calling for an end to the certificate of need process. And you know, the immediate answer, Dan, is no, we're not calling for an end to it. But I think to the point that Dr. Brumstead made, it needs to be carefully considered and evaluated as part of the picture here. Because if you're going to make comparisons, it's important to recognize that is a difference in how long it takes for something to move from an idea or need phase into an actual implementation and availability to Vermonters. Do we have another reporter who wants to ask a question, either in chat or verbally?
Yes, we have Leora, and I will unmute her.
Great. Hi, Leora.
Can you hear me?
We can.
Okay, so I wanted to ask, because I think when I wrote initially about the investigation, it sounded like the hospitals submitted some data that went in and sort of served as the basis of some of the findings. And so I want to sort of hear from you guys, did you submit any of the data? And like, if so, you would have then potentially known for a long time now that wait times have been an issue. And then sort of a follow-up to that is, you know, whose responsibility is it to sort of deal with it right now? Because it seems like, you guys are saying, okay, the regulators have something to do with it. You guys have something to do with it. But in the meantime, patients are suffering. So I just want to hear more about that. Thank you.
Yeah, Leora, let me start from where you just left off, and then we can talk about the data submission. I think this absolutely has to be a shared enterprise because there's no single stakeholder that has the resources or the capacity or the capability to solve a problem and as challenging and important as this one. I think there's a commitment from the hospital community to bring all of the best ideas and resources we can to the table. And that means getting support from our regulatory body and getting support from legislators in terms of workforce initiatives and Medicaid rate increases so that what we get paid keeps pace with the rate of inflation and allows our facilities to improve and invest in the equipment and the technology and the people they need to deliver the best possible care. Now, as far as the data submissions that hospitals gave as part of this process, I'll let the individual hospitals speak to that. I think it did vary a little bit from facility to facility based on how the inquiry was conducted. But Claudio, do you want to start with that one and then maybe we can go around?
Yes, we submitted data. We met with the team from the Agency of Human Services with some of our finance and operations folks to understand what they wanted for data and to give them that. I have not seen the report yet, And I don't know whether they used our data or they relied on the secret shopper data and the outside agency. But yes, we have submitted our data. And as I said, this is not new news to us. We know, especially it's not uniform across the board, but there are some areas that we know and have a solution that we're working on. We have some areas that we know that we haven't found the right solution yet. But yes, we have submitted data from Rutland Regional.
Great. Dr. Brumstead?
Yeah, we submitted data and answered every data request, and actually went further and had clinical and administrative leaders in very specific areas meet with the team from DFR, AHS, and the Green Mountain Care Board, just to explain our processes, the difficulties with access that we're finding, and what our crafted solutions are and the timeline for those implementations. And so we were all in on helping to inform the report in every way asked, and then some, bringing our folks to the table as well.
Thank you. Sean or Dr. McGraw, anything to add here?
Just agreeing, we submitted data, but I also want to stress that, like Claudio said, this is not news. We monitor our wait times very closely, as I know all our peer hospitals do across the entire state. And, the reality is, especially in a small community like ours, where you might have a specialist, you tend to see spikes when that specialist takes 2 weeks off vacation, or like I said, is out on maternity leave and you're struggling to find replacement. I mentioned that we were down, our 3-person surgical team is down to 2 and has been for over a year. We've been aggressively recruiting. We're filling the gap with locums, but that is not ideal, and it still lends to extended wait times for certain things like routine colonoscopies. We're hyper aware of it. We're laser focused on solving the problem, but they're wicked problems to solve.
Thank you. Beth, do we have any additional questions? We're a little bit past time, but we can take a couple more.
I don't think so, unless, I'm sorry. It looks like Colin and Dan might have follow-up questions. I'll start with Colin. Do you have a follow-up question?
I do, yeah. I'm just, as we're talking about data, and I'm curious as to whether any of the hospital leaders have any ideas of how we should be tracking this at a statewide level. I mean, up until now, there hasn't seemed to have been any effort to track this across the state. And I think a lot of people look at that and believe that that's kind of contributing to the problem, that we don't even know. I mean, I hear what you're saying, like this is something you're tracking internally, but from the outside looking in, it is very hard to understand what wait times are at any hospital. It's not a clear process. And what happens at the Green Mountain Care Board budget review, I mean, it's almost impossible to compare some of these things. So I'm just curious, if you're in the seat of deciding, okay, we need to start tracking this statewide, how would you do it if the secret shopper survey doesn't seem to have met your standard?
Yeah, so I think that needs to be a conversation that we have, going forward. The hospitals in Vermont are regulated very strictly, as I've mentioned, more so than elsewhere in the country, and already submit a trove of data to the Green Mountain Care Board around all kinds of issues, including quality and access and cost. And so I think, Colin, that we just want to be very thoughtful and again, collaborative in figuring out the best data set to answer these questions going forward, and one that produces real benefit that we can tangibly see and act on, but doesn't overburden hospitals. And I'll welcome the panelists to comment on that too. Okay, Claudio.
So I think we do need to do some work on trying to get a more common definition of what is appropriate wait time for what type of specialty, right? If you're having some chest pain and you need to see your cardiologist, or you've gone to the emergency department, they've ruled out something immediate, but they say you need to follow up with a cardiologist, there's some pretty general understanding in the medical community about how quickly the expectation is for you to get in. If you're getting referred from a primary care doc to a cardiologist just because you're having some hypertension and they're not able to work that up, or they have access problems, some mild high blood pressure, there's a very different standard there, as you can see, so that those limited specialists have the resources to take care of the more acute problems. So there's no easy answer to this, and we don't want to try to sound like we're being obfuscating and so forth. There's no clear, bright line metric for access. I think we can together try to find some. We have been submitting that data for a couple of years to the Green Mountain Care Board, but as I think it sounds like you're aware of this, Colin, it's in a very gross type of a thing, third next available appointment. Well, again, third next available appointment, it varies depending upon the clinical acuity of the patient on how quickly they need that.
Dr. Brumstead?
Yeah, I would just piggyback on that. We at the UVM Health Network, as I'm sure all the hospitals do, we track data on wait times, the number of people that arrive, no-show, wait times in the emergency room. I mean, there is a plethora of data, and all of those data we gather so that we can test how well we're doing, and where we're not doing well, usually against a benchmark, we dive in and try and solve those problems. The real issue, I would say, is in all of that, what information would be useful, and how can we get that information made available as efficiently as possible. The last thing, I'm telling you, the last thing that we can handle on the delivery system side is more administrative burden. That is just the proverbial straw. And so, we got lots of data. We use it internally to improve every single day, find where our opportunities are. And so it's not that we don't have the data, it's how would it be packaged to be useful, and how can that be done without adding more burden on the delivery system.
I want to agree with Dr. Brumstead on that, and extend it to just also say that we really need to look at what we would do with the data that we've already been submitting in various formats. Perhaps they can be collated better in presenting that information externally as at a statewide basis. But really the focus has to be, how do we address that? And that just circles back to workforce support, housing, as Sean Tester mentioned, and some of the other issues that are challenging, reimbursement, et cetera, in being able to bring clinicians here to the state to be able to increase access. This is not an issue of whether or not people are working hard. People are working really, really hard.
Yeah, I don't
Thank you. I
disagree with that. It just seems like all of the issues that you're talking about, the only way that anyone's ever going to know whether things are improving is if we have a data standard to compare it to. And what I'm hearing is that there are some problems with what's been offered by AHS, and that hospitals do have data. It sounds like this is a conversation for another day, but I am interested in, as someone who's reporting on this stuff, how can we best, frankly, hold you accountable to some of these things to make sure that improvements are being made? How do we know? I don't know if there's a question in there, but I'll leave it at that. Thank you.
Yeah, Colin, that's a fair observation. I would just say we're committed to having the conversation. One other piece of context here is that wait times represent one metric, or one way of looking at whether the system is working for patients. Another is outcomes, which is, how good are the results we get when a patient is injured or sick, and what is the outcomes at the end of that process. And Vermont routinely compares very favorably to peers around the country in that category. So I just think it's important to look at the whole picture. And I know we're just about at the end of our hour. Was there one more question, Beth?
Yeah, Dan D'Ambrosio, I'll allow him to talk, and that's it. Then we'll be
Okay.
done.
Go ahead, Dan.
Okay, thanks a lot. I just had a quick follow-up on the CON process. If we say, as Dr. Brumstead did, that it's hindering the response to the wait time problem, and we say we're not calling to get rid of it, does it at least need to be modified? It just seems like it's a very significant factor. And ironically, I mean, if I understand it correctly, the whole reason behind it is to make sure we don't have too much capacity. It would seem that we don't. So I'm just wondering if, yeah, I guess that's it. If you're not calling for it to go away, are you calling for it to change in some way?
Dr. Brumstead.
Yeah, this line of questioning is my fault, so I'll take that one. Dan, has to be part of the conversation. You've heard from all of us that no one sector can be solo and really make substantive progress. So all I was referring to is that the regulatory process that is very unique in Vermont, both on the budgeting and on certificate of need, needs to be part of the conversation if we're really going to all be working together collaboratively, as we've all suggested, to have the best solutions to increasing access for Vermonters.
Great. So I want to close out our event today and thank everyone for joining and for the thoughtful questions. None of the questions are easy or immediately answerable. Just know that hospitals are committed to doing so. I see up close every day working with our hospital leaders how devoted they are to making sure that they're making the right improvements and understanding the situation. We will continue to do that ourselves and in partnership with the state, and look forward to making improvements that Vermonters can see and feel. So thank you all very much for joining us, and have a great afternoon.
Thanks, everybody.